The approach that we've used, rather than using chemotherapies, which tend to be relatively non-selective, we've decided to harness the immune system to treat cancer. Using the immune system to treat cancer is not a novel approach in and of itself, in the sense that there are many antibodies that are commercially available now to treat various types of cancers. And also, if you look at bone marrow transplantation, is in and of itself a type of immunotherapy, because the donor immune system is infused into the patient, and that donor immune system can sometimes kill off remaining tumor cells. Here what we do is we cut to the chase, in the sense that we take a patient's own immune cells, T cells, which are programmed to target or to recognize proteins that are foreign and kill off any cells that express foreign proteins. And we re-engineer them, because a T cell, your own T cell, won't recognize proteins that are on your own cells. It recognizes things as being self or non-self. And so what has to happen is we have to make these immune cells, these T cells, which are capable of killing tumor cells ideally, we need to re-educate them to recognize the cancer cells as being foreign. And we can do that by, in the laboratory, engineering or creating a type of artificial receptor, which we term a CAR, or chimeric antigen receptor, and putting that gene into a virus that allows the gene to be inserted into the T cells. So what we do is we take a patient's own T cells, the patient has cancer, we take them and take the T cells, put them in the laboratory, we add this virus, which will bring the gene into these T cells. These T cells will then grow and express this artificial tumor-specific receptor. Once these cells have been expanded enough, they're infused back into the patient, and ideally, if this approach works, these T cells root out residual tumor cells or overt tumor cells and kill them. And unlike an antibody or a chemotherapy, these T cells ideally can persist and proliferate in the patient. So this is not the same paradigm as you would see in a new type of chemotherapy, where repeated infusions would likely be necessary. Now, to date, we've used this approach targeting a protein called CD19, which is expressed on lymphoid cells, or B cells. And there's multiple types of cancers that are derived from B cells, such as diffuse large cell lymphomas, chronic lymphocytic leukemias, as well as acute lymphoblastic leukemias. And they all express this CD19 protein. And so that is the first target that we have approached, and we and others are targeting CD19 as I guess a proof of principle. But also, ALL is a very difficult disease to treat in adults, and CLL is incurable. So there are many B-cell tumors which are ideal targets for novel therapies, or that require novel therapies. The plan moving forward is to find other proteins on other types of cancers, like solid tumors, such as MUC16, which is one target protein, glycoprotein, that we've generated a receptor to, as well as mesothelin, PSMA. There's a whole variety of proteins that could ideally be targeted using this methodology. In the clinic so far, we've had some success with chronic lymphocytic leukemias, patients that have relapsed chronic lymphocytic leukemias. But perhaps even more, which I'll present today, even more dramatic responses have been seen in patients that have chemotherapy refractory relapsed acute lymphoblastic leukemia. And in adults, this is a highly, highly lethal disease with a very poor prognosis. And we were able, in 2 out of 2 patients, to achieve a complete remission, allowing these patients to move on to bone marrow transplantation, which they otherwise would not have been able to.